All right, everybody, thank you. As the last stragglers entered the room, my name's Mel Miller. I'm the current chair of the advisory board of NDARC, and it's a great privilege and pleasure to have that role, especially as I reflect on sitting on the then Intergovernmental Committee on Drugs, I hate to say 40 plus years ago, where we argued for the establishment of the national centres and to see how much has been achieved by them and their impact on evidence-based public policy. The other thing I'd like to do very quickly before I introduce the first speaker in this session, which is a speed dating version of poster presentations, only 3 minutes each and no questions, I'd like to acknowledge the presence of one of the founding mothers of alcohol and other drug research and public policy advocacy, and dear friend, Professor Margaret Hamilton. So welcome, Margaret, wherever you are in the room. Our first speaker is Joanna Zhou. Is a fourth-year undergraduate medical student at UNSW and is currently in her research year. Her field of interest is female reproductive health, and her project on OAT retention in postpartum women has enhanced her ability to contribute to research in healthcare benefiting women and children. Joanna.
So before I start, I'd like to acknowledge my supervisor, Danielle, and other authors of this study titled Retention in Opioid Agonist Therapy After Childbirth. Okay. Yes, okay. So pregnancy has 3 trimesters, but have you heard of the 4th trimester? It is a phrase used to describe the emotionally and physically challenging period after childbirth. And in this period, women with opioid use disorder are especially vulnerable, as it is clinically recommended that they continue on opioid agonist therapy, which we'll abbreviate to OAT. And as treatment, women are prescribed either methadone or buprenorphine, and this helps to prevent withdrawal and cravings. And retention on OAT reduces high-risk behaviour, relapse, overdose, and mortality risks, and additionally, it helps promote a stabler home environment and better care adherence. However, we know little about OAT retention in Australia. And that's why we examined the extent to which Australian women were retained on treatment after childbirth and explored a range of factors associated with better retention. And so to conduct this, we linked OAT data to records of childbirths between the 1st of January 2004 and the 31st of March 2020. And we included women who received OAT at the time of childbirth. We defined retention as continuous OAT with no break over 7 days, excluding or modifying this to 37 days for buprenorphine in custody settings since September 2019. And here are our findings. In our final cohort of 3,933 women, or childbirth, to 2,514 women, we found that retention was substantially high, being 93.3% at 90 days, 84.4% at 180 days, and 78.5% at 365 days after childbirth. And we also examined retention according to a range of factors using generalized linear modeling. And as we can see in the forest plot, at 90 days we found substantial variation according to the timing of OAT, where compared to women who received OAT before conception, those initiating in the 3rd trimester had lower retention. Women who overdosed in the year before conception until delivery also had substantially lower retention, or higher retention, compared to their counterparts who didn't. And for other factors such as age group and Indigenous status, maternal morbidity risks, which included mental health or smoking, and birth outcomes or complications, there was moderate variation. And results at 180 days and 365 days showed similar variation patterns. So, to conclude, it is very reassuring to see that most women continued on treatment after giving birth. However, our findings do indicate and highlight the importance of more targeted interventions to help engage women in treatment earlier, even before pregnancy, to enhance continuation of treatment in the so-called 4th trimester. Thank you.
Brilliant, thanks, Joanna. Almost bang on time. So I'd like to now introduce Kendal Chidwick. He's a Pharmacoepidemiologist, try and say that fast, with 20 years experience, including over a decade in research. She previously led the Medicine Insight real-world research team at the NPS, Medicine Wise. She's currently working on projects to describe trends in Australian sales of opioids and opioid agonist treatments, initiation of opioids post-hospital, and the impact of the introduction of long-acting injectable buprenorphine.
Thanks for that. So in Australia, you're probably all aware, a raft of measures have been introduced to curb the use of prescription opioids. And we know this has been successful in terms of reducing PBS dispensings of opioids, but we don't have a clear view on what's happening with non-PBS supply of prescription opioid analgesics for pain. So that includes private prescriptions where the patient pays for the entire cost, and public hospital inpatient use of opioids. So we used national IQVIA sales data to look at trends in total prescribed opioid use, as well as sales of opioids to community pharmacies, hospitals and other settings, including PBS and non-PBS use. And we use PBS 10% data extrapolated to estimate national use. And by subtracting the PBS dispensing data from total sales, we could estimate non-PBS use in Australia. So the figure on the left shows us that total use of opioids has been declining between 2015 and 2022 by 21%. And that's largely due to the reductions in PBS dispensing in green there at the top of those vertical bars, with non-PBS use represented in blue at the bottom of those vertical bars. And so that non-PBS use we can see has been increasing over time, and it's offset a quarter of the reduction in PBS dispensings. I don't have it on the slide here, but we know that sales to hospitals remain steady over this time at about 8 to 10% of national use. So the increases in non-PBS use were due to increases in private prescriptions for opioid analgesics. Now, the orange line on both those figures shows the contribution of non-PBS use to total prescribed opioid use over time, and it's increased from about 14% in 2015 to 27% in 2022. And on the right-hand figure, we can see the story's a bit different when you break it down by immediate release or fast-acting opioids compared to the controlled release. So non-PBS use is much higher for the immediate release fast-acting opioids, and by 2022, of all immediate release opioids sold, 50% were PBS dispensed, whereas 50% were either private prescriptions or in hospitals. Important to note that controlled release opioids are most commonly used in Australia. And so with this new information, it helps us interpret PBS data going forward, interpret policy, and understand how to use PBS data for research. Thank you.
Thanks so much. I'd like to now introduce Dr. Ria Hopkins, who's a postdoctoral fellow with an interest in pharmacoepidemiology, public health and healthcare policy. Her current work includes projects aimed at identifying patterns of medicine use and associated outcomes, and is particularly interested in potentially high-risk medicines such as opioid analgesics and priority populations, including people living with pain. Welcome, Ria.
All right, thank you. Perfect. All right, so deaths of despair is a relatively new concept that's been kicking around that groups deaths due to substance poisonings, alcohol-related disease and suicides together, based on their shared socioeconomic, structural and personal drivers of these deaths, such as disempowerment and disadvantage, mental health conditions and substance use disorders. Additionally, some researchers have posited that deaths of despair represent a distinct epidemiological phenomenon, and we wanted to test this theory here in Australia. So we performed a side-by-side comparison of these deaths using almost 40 years of Australian cause of death data, including examining age at time of death or age, year of death or period, and year of birth or cohort effects. So here I've presented the age standardised rates of these deaths over time, and you can immediately see that there are different distinct patterns evident between the causes of death as well as between sexes. So for example, alcohol-related disease deaths have gradually declined for men over the last 40 years, while substance poisoning deaths have shown periods of increasing and decreasing rates of deaths. Comparatively, rates appear to be relatively stable for females. So I didn't want to overload you with figures, but I'd invite you to come and check out our poster or to look up and read our paper, where we present age-specific annual percent changes and net drifts, birth cohort rate ratios, as well as hexamaps of mortality rates as a function of age, cohort, and period effects, all of which really reinforce the findings that the trends and the patterns differ between these causes of death and between sexes. So overall, there remains value in considering these causes of death together because of their shared drivers and determinants, and also because of the overlap in potential prevention and intervention strategies, particularly at the structural and systemic levels. However, our findings challenge the notion of deaths of despair as a single unitary construct that represents a distinct epidemiological phenomenon. And because of that, we advise caution when analysing these deaths together. We also show, if you look at just the 1980 versus 2020 numbers, so for example, for the combined rates, if you only looked at those two numbers, you might get the impression that these deaths have been stable and haven't changed over time. And there's a need to really break these things down and look at them at the nuanced level. And then finally, I'm just going to go a little bit off script here because I've got time. But in light of the release of the report from the Royal Commission into Veteran Suicide, as well as the ongoing public consultation into the government's suicide prevention strategy, I just wanted to highlight that suicide remained the most common cause of these three deaths over the 40-year period, and that despite ongoing interventions and prevention strategies, it really hasn't come down substantially. And I think that really shows that there's a need for more work in this area. Thanks.
Thanks, Ria. And now I'd like to introduce Olivia Price, who commenced her PhD in 2020, working with Louisa and Amy, and her project focuses on vaccine-preventable diseases and sexually transmitted infections among people who inject drugs, and aims to examine access to relevant interventions and the burden of disease among this population. She also works in a part-time capacity on the drug trends team, exploring trends in illicit drug use, behaviours and markets.
Hi. I'd just like to start by acknowledging a very long list of co-authors who've helped with this work, particularly Dan, whose work in the UK we replicated for this study. So data from multiple sources suggests that the age of people who inject drugs in Australia is increasing. So we see this in household survey data, in drug treatment episodes, and in drug-induced deaths. And the purpose of this study was to explore why we're seeing this population change. And there were several theories that we wanted to examine. Is the population ageing because people are starting to inject drugs at an older age? Are people injecting drugs for a longer period of time? Or is there a cohort effect where the age of the population is a result of a large group of people injecting drugs beginning to inject drugs at a similar time? And we also wanted to investigate the role that drug markets might play in this phenomenon. So we used 20 years of data from 2 Australian national surveys with people who inject drugs, the Illicit Drug Reporting System and the Australian National Needle and Syringe Program Survey, which is a Kirby dataset. And we did examine all the theories that I just mentioned, but I'm just going to give you the answer straight away for this 3-minute presentation. So this graph, you can see people reported the year that they began injecting drugs, and you can see that there's a clear peak in during the 90s, which is indicative of a cohort effect. And the different colours on this graph represent the different years people were surveyed. So you can see that the result is consistent no matter when the participants were surveyed. We then used the relative number of people who began injecting drugs each year, as well as existing population size estimates in Australia, to model the number of people beginning to inject drugs each year. So this is the model result, and the model allows for people leaving the population due to either injecting cessation or death. And the model suggests that the numbers of people beginning to inject drugs each year was actually relatively stable through the 80s and into the early 90s, before there was quite a stark and sustained decline in the mid to late 90s. And the graph is disaggregated by drug injected first, and you can see that the drug markets do play a role in what people are injecting first. You can see that second orange peak of heroin was during a time of quite readily available and cheap heroin, but it doesn't seem to have impacted the number of injecting drugs for the first time overall. So our conclusion was that a large cohort of people who began injecting drugs in the 80s and 90s is the reason that the population today is ageing. And as a result, the population of people injecting drugs in Australia today is older and has been injecting drugs longer than the population in the year 2000. Thank you.
Thank you so much, Olivia. I'd like to introduce Dr. Tayla Degan, who's postdoctoral fellow and registered clinical psychologist working in private practice. She's expertise in working with people accessing substance use disorder treatment and mental health services, and experience working across multiple research trials. She was previously a clinical psychologist for Corrective Services New South Wales. Welcome.
Cool, my slides are really small, that's all good. Hi everyone, so today we'll be presenting on a paper that is part of a larger cohort study using the MATES data set, looking at co-occurring DSM-IV mental disorders amongst people with methamphetamine dependence. Cool. So we know that methamphetamine dependence is a global public health concern and prevalence rates are increasing. We also know that there are high prevalence rates of co-occurring mental disorders amongst people with methamphetamine dependence. We know that in substance use disorder populations more generally, that co-occurring mental disorders are often associated with poorer health outcomes, higher poorer treatment outcomes, and poorer or more relapse rates. We don't know a whole lot when it comes to methamphetamine dependence when we're talking about the number of co-occurring DSM disorders and how this impacts on this population, and so this is what we aim to do. So we aim to estimate the past year prevalence of DSM-IV co-occurring disorders amongst people with methamphetamine dependence and the number of co-occurring disorders, and to see and examine the impact that number of co-occurring mental disorders has on this population's quality of life. We also wanted to explore whether they actually received help for these co-occurring disorders, and so we did this again using the MATES cohort data. We had 484 adults that were involved in this current study, all with a methamphetamine use disorder. We used the city to diagnose DSM-IV mental disorders of major depressive disorder, panic disorder, and social phobia, and we used the SF-12 to measure their quality of life. So we found that in total, 57% had a co-occurring mental disorder of major depressive disorder, social phobia, or panic disorder, and depression was the most common mental disorder, so 44% had depression. We found that 31% had one co-occurring disorder, 15% had two co-occurring disorders, and there was 11% that had all three co-occurring disorders. We found that as the number of co-occurring disorders increased for this group, their mental health status or their mental health quality of life decreased. And we found for that people who had 2 and 3 co-occurring mental disorders that they also showed lower physical health status. We found that of the people who, 53% of people received help for at least one co-occurring disorder, and of those people who did receive help, 81% felt that they did not receive as much as they actually needed. So this study really highlights the high prevalence rates amongst this population, and that they often, mental disorders often co-occur. We know that services need to assess and manage these co-occurring mental health disorders to help improve mental and physical health status amongst this group. You can also use the QR code to the PDF and see the poster at the poster station. Thank you.
Thank you, Tayla. I'd like to now introduce Dr. Emily Symes, who's a consultant emergency physician and clinical toxicology fellow at Sydney Local Hospital District and a PhD candidate at NDARC, supervised by Louisa and Rachel, exploring the epidemiology of substance use and mental health in trans and gender diverse people. She's also Vice Chair of LGBTIQA+ Association of Doctors and Dentists Australia and a proud member of the trans and gender diverse community. Welcome, Emily.
Thank you very much. A bit of a different topic now. Our presentation sort of explores the presentations and characteristics of trans and gender diverse people presenting to an Australian ED. Just to provide everyone with a bit of background, so trans and gender diverse people experience significant health inequalities and multiple barriers when accessing healthcare. And they also experience higher rates of negative healthcare experiences. And the literature that evaluates the emergency care of trans and gender diverse people is quite sparse. It's predominantly qualitative, and it typically only evaluates a specific subset of people that present to the ED, such as US Medicare beneficiaries. So as a result, the aim of the study was to evaluate patient and presentation characteristics of gender diverse people presenting to the ED, as well as potential contributors to negative healthcare experiences. So we've conducted a retrospective case series that looks at trans and gender diverse people of all ages presenting to a tertiary inner city emergency department in Sydney, Australia over a 5-year period. So as you can imagine, it's very difficult to identify trans and gender diverse people. So we actually developed a novel method to try to identify this patient cohort using the ED patient tracking system and clinical notes in the electronic medical records. And we extracted variables, including patient characteristics, their ED presentation characteristics, and some potential contributors to negative healthcare experiences. And so these things include mismatch of gender and or name in the electronic medical record, as well as instances of misgendering and dead naming on the discharge letter. And so these refer to referring to someone by their former gender or pronoun or their former name. So here is just a summary of the results, and apologies, it's a bit of a busy slide, but just to highlight a few key facts. So just using the pie chart on your far left there. Actually, prior to that, we've identified 340 unique patients, and there's 1,519 presentations among these patients. Now with that pie chart there, this is sort of depicting the acuity of ED presentations. So as you can see, our population, there is roughly 3/4 presented with high acuity presentations. So these were category 1, 2, 3, which correspond to emergency resuscitation or urgent presentations, which was much higher than the general New South Wales ED population, which was roughly 40%. Roughly 1/4 of our patients were admitted to hospital, which was much higher than the ED population studies in Australia, which are less than 20%. And there was also a higher proportion of patients that left prior to completing treatment. Looking on the sort of top 5 ED diagnoses, mental health problems were the most common by far, and more than 10 times that of the general ED population. And finally, in terms of contributors to negative healthcare experiences, approximately a half were misgendered or had their gender incorrectly listed in the electronic medical record, and a third had an incorrect name as well. And then unfortunately, 1/4 were misgendered or dead named on their discharge letter. So we've got a few implications, which feel free to ask me on the poster. And we made a few recommendations for clinicians to improve the care of gender diverse people in the ED. Thank you.
Well, that's extraordinary. I think we were on time. The audience was late coming in, so congratulations. It's an extraordinary ask to ask people to present such complex studies in a few minutes. So thank you to each of our 6 speakers. I'd like to now hand over to Professor Nadine Ezard, who's going to chair the next plenary session.
Brilliant, thank you. I'll try and emulate your success with timekeeping. It's my great pleasure now to introduce Shane Darke to the stage. Many of you will know Shane. He's well known to many of us for a long time. He's been with NDARC since 1988, probably before some people in the room were born, and he's a leading world expert on morbidity and mortality associated with illicit drug use. Most. He's written many seminal works, particularly on opioid overdose, and has published widely in the area of illicit drug use, including work on opioid overdose, psychostimulant overdose, psychopathology, suicide trauma, treatment outcome toxicology. He's published more than 300 articles, 6 books, 85 monographs, 8 book chapters, and he is also the regional editor of Addiction for Australasia and Southeast Asia, associate editor of both Drug and Alcohol Dependence and Drug and Alcohol Dependence Reports, in case you didn't trust his bio. Thank you, Shane.
Thank you, Nadine, and thank you all for your attendance today. I'm not going to bore you with a large number of very busy slides. I'm going to achieve it almost unaided, thank you very much. You'll all get 10 years of purgatory. The topic today is one that, on overdose, is one that I've been exploring continuously for the last 30 years. And as the Chair kindly points out, most of you weren't even born then. But it's one of the greatest public health significance, greatest clinical significance, and also greatest personal significance. Each overdose death is a tragedy, and each overdose death is potentially avoidable. So in the last 30 years, what we've been trying to do is understand what causes various types of overdoses, and by understanding that, how one can intervene to reduce the harm. There was a view in the early 90s that overdoses, and particularly opioid overdoses, were essentially random events. And our trouble with random events is, by definition, it's very hard to know what to do about them. And really, what we've shown is that that is not the case. So what I want to do is look at 3 waves of types of drugs and look at, for instance, in the opioids, the psychostimulants, and the so-called new psychoactives. For each of them, I want to ask 3 simple questions. What is an overdose for those drugs? Who it is overdoses and has that changed? And what are the known risk factors? So, and I should point out that when a new wave of drugs comes in, it doesn't mean the old one goes away. For instance, things wax and wane, but a study we did, for instance, on heroin, which tends to slip out of the media these days, showed we documented 610 fatal overdoses in Australia between 2020 and 2022. So things do not go away. So I want to start with the opioids and looking at what it means to have an overdose from an opioid. And as the title suggests, it's about respiration. So looking at first, it's important, what is an opioid overdose? Well, all opioids, and I'm including drugs such as heroin, oxycodone, I'll cover the nitazines and drugs like that later. They're all respiratory depressants. They're central nervous depressants that suppress respiration. Now, even in people with quite heavy tolerance, we can see people shortly after the use of, say, heroin, respiration reduced to about 4 breaths per minute with consequent reduction in oxygenation. This can have obviously implications for oxygenation to the brain and other organs, but this comes out of work that Professor Strang did in the last few years. And not only that, the respiratory effects, depressant effects, can last beyond the peak period of the concentration in the blood. It seems to be like it's set and then it has to be reset. So the risk can be elongated. So death in opioids is due to respiratory failure. Although, and I should point out, so there is this cascade that you see quite often, that people just cascading through lower respiration and states of consciousness through coma to death. But the reduction in oxygenation can also induce a cardiac arrest. So this would be secondary to the oxygen deprivation. A third thing that I think we need to look at is, and I think it's sometimes overlooked, opioids are emetics, that is, they induce vomiting, and they're cough suppressants. When Professor Strang showed us those pictures of early 20th century heroin, it was marketed as a cough suppressant. So what you find then, that's a sometimes fatal combination, because people are vomiting and aspirating vomit into the lungs and not coughing, lacking the cough reflex. And so what you see in overdoses, quite often you see aspiration, that's vomit in the lungs, and acute pneumonia, which is a reaction to the presence of these irritants in the lungs. And these can contribute to death. Now, one thing, as I said, we were told many things in the early 90s, and God knows what I was telling people, but probably been banging on about rubbish for 30 years, but for your sins, you're going to be exposed to more of it. But we were told that people just dropped down dead from when they took a heroin overdose, no time to intervene. And of course, this was based on no data. When we first looked at time to death, it looked, just from reading autopsy reports and police narratives, that there was time. But in more recent years, we actually could look at biomarkers that could tell how long generally a person has, from when they've used heroin to death, that they survived. And basically, in more than half, people survive at least 30 minutes. And we think that people who, the actually person who takes a shot and drops down dead is unusual. Now, this is for heroin. I'm going to talk about the new psychoactives in a minute. But I just want to point out, with heroin, that is one thing we've found, there is time to intervene. And this is why, the provision of naloxone to individuals, they're not going to use it on themselves, but their partner may well use it on them, particularly now with the new nasal preparations. There is time in most cases. So let's say, who is it that overdoses, and has it changed? Well, actually in fact all drugs, or certainly all illicit drugs, the majority are male. That reflects in part the epidemiology of illicit drug use, that is that it's more males use than females. But there's also some suggestion that more males are likely to use alone, with aid not being available. So the actual, it does seem to be an overrepresentation, even allowing for the epidemiology. Now, we'll stick with heroin just for the moment. The age of deaths, like the study that I just quoted, the mean age was about 42, 43. Now, when I started looking at deaths, so we did some work, Sandra Sunjic, I see, is in the audience here, thinking back, she was alive in the 90s. Looking back to the 90s, the average age would have been in about 30 from our original studies. And I should point out, the it's rarely teenagers. That's going to be the one that hits the media. Less than 2% of cases of people under the age of 20. It's mostly old hands. So the idea it's young and experienced people, that's complete nonsense. There's people who know very experienced. But looking at the trend across time, it's also looking at the other end, which surprisingly is an end I've become more and more interested in. But it's when we first started doing it in the 90s, say 96, 97, mean age of 30, upper age of, this is deaths, upper age around 50s, late 50s. Now people are aged in their 70s. Now, we find, there's people who've died of heroin overdoses in their late 70s. NPS is slightly different, I'll talk about. One difference I will say, oxycodone, two groups, the population I'm talking about, and older people, chronic pain patients who are at risk. And I think we sometimes forget about in terms of our interventions and providing naloxone too. What are the risk factors? Previous overdose. Risk predicts risk. From longitudinal work we did some years ago, someone overdoses in 1 year, they're 6 times more likely to overdose in the next. And not only does it predict more non-fatal overdoses, the history predicts fatal overdoses. Return to use after a period of abstinence, whether that be prison, the first 2 weeks after prison, Professor Farrell's groundbreaking work on that, and coming out of detox, for example. Detox is not a treatment, it's got to go somewhere. What you may have done is actually reduce tolerance, people reinstate, and they're at higher risk. Polysubstance use. Drug-related deaths using one drug are rare. Other drugs that are relevant here are the other respiratory depressants, the ones we were talking about earlier on, benzodiazepines, alcohol, obvious ones. Now, the point is that you may have an opioid, alcohol and a benzo on board, neither the level of which would not kill you, any one of which, but the combined respiratory depression does. Route of administration, injecting quick bolus to the brain, far higher risk. Don't get me wrong, we've documented deaths from people who have either swallowed opioid, I'm thinking here of heroin, or snorted it, or smoked it. It's rarer, but it can occur. But injecting any opioid increases risk. And finally, one that's not explored very often, emphysema, chronic obstructive pulmonary disease. Something like when we do our fatalities, about 20% of heroin deaths are diagnosed with emphysema. And it's difficult to diagnose post-mortem, so it's an underestimate. It's estimated roughly about 30% of injecting drug users who use heroin, and some 50% of heroin smokers, which is something you'd far more see in the UK. Does this matter? Well, reduced respiratory reserve with drugs that cause reductions in respiration. So it does matter, and I think it's something we have not explored to any great detail. Let's move on to the psychostims, by which we're primarily talking methamphetamine, cocaine, MDMA. Heart and brain, very different. What is an overdose? It's not even clear the terminology is correct. It's really based on opioids and alcohol, the respiratory depressant model. This is a very different presentation. Now, coming in from about 2001, after the 90s explosion, we saw the explosion in this country of methamphetamine. More recent years, cocaine. cases of acute psychostimulant toxicity are actually cardiovascular and neurological events. We're not talking respiration here. The physical effects of psychostimulant toxicity, and if you're looking at coke and meth, they're pretty much the same. Meth does seem, it lasts longer, so probably has greater risk, does seem to be more toxic. Arrhythmias, that is irregular heartbeat, accelerated heartbeat, hypertension, spikes in hypertension, hypothermia, that can be very high temperature, unable to be reduced, which can actually result in rhabdomyolysis, causing muscle meltdown, and seizures and strokes. We'll come back to that in a sec. Cardiovascular and neurological. There's also a behavioural component which is harder to... stimulants are highly, they activate people. So there's, for instance, what was termed a agitated delirium, highly agitated people running around, putting themselves at risk, and in some cases actually running to the point where they actually have coronary events. This of course, you know, it does put people in risk more broadly, like driving on the wrong side of the road, 120 k's, that type of thing. But there is, the behavioural component is something that's quite, with opioids, people basically go to sleep. It's very different here. But I just want to get across, we're not talking respiration. Now, to come back to the brain, all psychostimulants have elevated risk of seizure. So fitting is one aspect that we see that's not seen with the opioids. Stroke. There's an elevated risk. Methamphetamine use 5 times increased risk of a hemorrhagic stroke, that is a bleed in the brain. Coke 2 times. And coke also can induce ischemic stroke, that is blockage of the coronary arteries, the vessels. Now, does this matter? Well, obviously, but we did a study looking at all deaths amongst young people in Australia that were related to strokes. Now, young people in medicine and design, and this will please many of you, anybody under the age of 45. So I think some of you are thinking, whoa, maximum respect. We found 1/5 of those cases. That's, the reason they're saying it's rare. Stroke's typically a couple of decades on. 1 in 5 were related to the person took a psychostimulant and had a stroke. These were bleeds, and the main mechanism here is hypertension, the hypertensive spikes. Bursting aneurysms, which people may have gone for years and died with and never burst. It does in this environment. And they're deeper in the brain and more catastrophic. 3% of non-users of drugs who have a stroke, that's the fatality rate, 30% amongst stimulant users. Who overdoses and has it changed? Well, meth and coke, mid to late 30s, but again, I've documented cases recently in their 70s of cocaine overdose. It's shifted up. And of course, you're talking about people with problems, heart problems. Cocaine seems to have changed, broader footprint, more people who you wouldn't expect, no history, and they're suddenly dead. The problem we find with many of these drugs is no clear dose response. People can have idiopathic reactions. So what then is the risk? Well, accelerated cardiovascular disease. These drugs cause enlargement of the heart, they cause clogging of the arteries, dilation of the ventricles, all of which reduce the pumping efficiency of the heart. And then you put a drug in that puts pressure on the cardiovascular system, so you have a cycle. Importantly, route of administration is not important for that. It's the drug. it's the drug. You can snort the drug, you can smoke the drug, you can inject the drug. The drug is what's causing heart disease. And polypharmacy, slightly different. Alcohol and cocaine, for example, produce a metabolite called cocoethylene. It's quite an unusual thing. It's a psychoactive metabolite which extends and intensifies intoxication. And methamphetamine in alcohol actually increases heart rate above meth alone. So we don't think of those, but it is the case. Other drugs that are serotonergic drugs such as tramadol can increase the risk of seizures and arrhythmias. And opioids reduce oxygenation while stimulants increase the heart need for oxygenation, increasing your risk of arrhythmias. Now, the new psychoactive substances. Now, no talk worth its salt omits a quote from the great one, David, maximum respect there. Same old thing in brand new drag comes sweeping into view. Now, David was talking about the new wave, boys and girls, of which I was proudly one, but it's opposite to these drugs, because many of these drugs are really, really old new drugs, synthesised in the 50s, 60s and 70s, the difference being that they've been taken up into use. Many of them were synthesised and never released, those being too dangerous. Now, I would just like to broadly say, what are they? Because by the time I finished, 10 more would have come on the market. 3 broad categories, in my opinion. The only new boy and girl on the block is the synthetic cannabinoid receptor agonists. They are not synthetic marijuana. There's no THC, it's nothing related. Do you know what they look like? They look like stimulants. The effects are hypertension, that type of thing. They look, in terms of their effects upon they're basically a heart and brain type of drug, but they're not marijuana, they're not cannabis. I think the second broad group is the synthetic stimulants and hallucinogens. I put them together, things like M-bone, because they overlap so much. This is just a simple tripartite thing so that I could get my head around the field. And finally, a series of depressants, fentanyl, analogues, knockoff fentanyls, other ones like U47700, and more recently the nitazines, GHP, liquid ecstasy. It's not. I have no idea. And a number of designer benzos. All of those things, like the fentanyls, the designer benzos, highly potent, variable times in action, and it's these are old drugs. What is new is that they're being mass-produced and put onto a market. Drugs that was considered too dangerous to use clinically are being put on the market. Now, we've seen deaths in all 3 of these categories in Australia. And as I said, what are they overdoses? Well, they're the same as what we've just talked about. Depressant overdoses are depressant overdoses. Stimulant overdoses are stimulant overdoses. If we had this conversation in 30 years, dear God, let's hope not, these drugs would be folded into existing categories. Synthetic cannabinoids absolutely look like stimulants, and I think we should think of them that way. The only thing about the benzos and opioids, they're very, very toxic, and it looks like many of them, death appears much more rapid, like the nitazine, so potent. So you're seeing less acute pneumonia, which takes time to develop. It looks like these are highly, highly risky. Who overdoses? Again, mostly male, no surprise. Younger mostly, 20 to 30s, reflecting in a lot of people get it off the net, the drugs. SCRAs are a bit later in the 30s, and we do get people in their 50s. GHB's accelerated since 2016, interestingly. The number of hospitalisations, emergency attendances, treatment and deaths. And they become older and it's spread. This is a different trend, spread into the broader existing drug-using population, established users adding this to their suite of drugs. So the risk factors, well, they're the same. As I've said, they're the same as the ones we've discussed with the previous two. I would say that the benzos and opioids provide far greater the risk because of their potency, particularly if you're going to use a potent opioid like a nitazene and then add a benzodiazepine to it or alcohol. I would just, before I end, quickly say there's a myth I've heard sometimes that drugs like the nitazenes aren't reversible by, or fentanyl aren't reversible by naloxone. It's all opioids are reversible by naloxone. You may need high doses and more doses. So that's basically the last 30 years. If we look, there is a reference, if you're interested, the Pocket Guide covers all of this, and I did a series of lectures that are on our website on this. I will just sum up then over this thing with another quote from David Bowie, from his excellent album Heathen. Nothing has changed, everything has changed. Thank you.
Thanks, Shane. I appreciate those references to David Bowie, and thank you for taking us through that survey of poisonings and overdoses due to various drug classes. I'm pleased now to introduce our next speaker, Dr. Brendan Clifford, who works with me at the National Centre for Clinical Research on Emerging Drugs, and he leads the translational implementational policy program of work there. Brendan has an interesting background. He's a clinician researcher who uses interdisciplinary methods to further health equity and enhance access to evidence-based healthcare. He's worked in a broad clinical background, having worked in nursing in Ireland, the United Kingdom and Australia, usually in emergency department settings. And in addition to undertaking clinical research in alcohol and other drugs, he's also held roles in inclusive health, innovation and health professional education, as well as the Drug and Alcohol Nurses Association of Australasia. So thank you, Brendan.
Thanks, Nadine, and thanks for the opportunity to speak. So I'm going to be presenting the Prompt Response Network. Before I do that, I would like to acknowledge the traditional custodians of the land that are meeting today, the Gadigal people of the Eora Nation. Acknowledge there always was, always will be Aboriginal land. The Prompt Response Network is a national network of agencies that are involved in detecting and responding to new and psychoactive substances as they appear to promote a timely public health response to reduce the harmful effects of emerging drugs. So we're broadly based on having quarterly national network meetings as well as monthly jurisdictional meetings. We have an information resource hub called The Know that has a public-facing website of drug alerts, and the Know community platform, which is an online knowledge exchange platform for people. We are funded by the Commonwealth Department of Health through the National ICE Action Strategy and overseen by NCRED to do this work. The Prompt Response Network itself is about 85 agencies that are connected together across Australia. We've reached into every state and territory, and we work closely with consumer representative organisations, harm reduction services, clinical services, toxicology services, government health bodies, police and researchers, so that we've got that kind of reach into where signals are and who needs to know about them to act on them. This just gives you a range of the spread. We're predominant. It's a good spread across each of them. We're a lot of researchers there because that's often where the signals are coming from, but also government health agencies, decision makers and toxicology services. This is our knowledge exchange platform, the Know community. It has a live feed where you get updates about drug alerts as they're released, as well as just relevant reports. There's fora where you can discuss topics such as nitazenes or vaping. discussion groups that some of them are closed to ensure or to support sensitive information sharing if that's appropriate. And there's also some resources, and it becomes a resource itself as the more established it becomes. The website republishes government-issued drug alerts in Australia with co-designed brand guidelines for consumer acceptability, and we work closely with jurisdictions to ensure that we've got the appropriate permissions to republish, and always targeting to supplement existing processes to avoid burden, because those government departments are generally very busy government departments. This just gives you a schematic of where the prompt response network kind of fits in. Drug alerts are issued at a state and territory level where early warning systems exist. Signals that ultimately get analysed to result in a decision that happens at a state level. And the prompt response network makes sure that all of the other states and territories know about it. And we've got a few different mechanisms that I've just spoken about to support that. So the No website for publicly issued drug alerts, but also we've got email lists and the platforms for either drug signals that haven't resulted in a drug alert, a targeted drug alert, and also where there's no early warning system in a state or territory, we can still support information sharing so that that data is still acknowledged and captured. What I'll do in this presentation is just briefly run through what's been happening in the last year in terms of new psychoactive substances, as kind of demonstrated by the drug alerts that are being issued, as more and more agencies and more governments come aligned to issue drug alerts. So between August last year and August this year, there were 43 public drug warnings and community notices referring to 61 drugs or drug classes of concern. There's still quite a considerable heterogeneity in the way drug alerts get issued and what they refer to. So not every drug alert specifies a drug or a drug harm. So here you can see we've mostly the most frequent group are still the opioids. Again, the nitazenes are quite predominant there, but heroin is still very much present. Then empathogens, which is MDMA. There have been a lot of high purity MDMA alerts. And then the stimulants are the next. I'll go through these in a little bit more detail. So nitazenes, Professor Darke spoke about. They are a class of drugs that were initially developed in the 1950s. New ones are still being developed. We're up to about 25 nitazenes at the moment. Etonitazene there is alarmingly 1,000 times the potency of morphine. And the number of drug alerts related to nitazenes is steadily increasing. The first alerts were in 2022. There was 4 across Australia, 6 last year, and already to September this year, there was 1 just last week. There have been 7 alerts related to a nitazene drug. Other data, so we know from EDNA, the Emergency Department Toxic Surveillance Monitoring System, there have been 22 detections. That was in, I think, May this year. And detections are across different routes of administration. So oral, insufflation, inhalation, rectal administration, and injection. So lots of different ways that it can present. Intentional and unintentional use. So the unintentional use is particularly concerning, and as well as that, it's found not just in other opioids, but other non-opioids. So ketamine, MDMA, cocaine, benzodiazepines, novel psychedelics have all had detections of nitazenes in them. Some recent work by Professor Darke has showed 17 deaths in coronial reviews. That's when we know from other sources that there's been at least 16 deaths in Victoria and 7 reported in South Australia. We've done a couple of things for the PRN to support responses to nitazenes. We've put out a brief in April this year just to characterise the issue and just offer what the evidence kind of suggests would be most appropriate, obviously focusing on naloxone, which is, as Shane says, effective. You might need more of it and you might need repeated doses, but naloxone is certainly going to be the mainstay of any response to any increases in nitazenes. We've also put out just a couple of webinars to support information, and they're online currently as well if you go to the NCRED website. Otherwise, our second biggest group, as I said, was their empathogens. Mostly that was high-dose MDMA. Concerningly, there were nitazenes detected in some MDMA in January this year. But also those are the other things that are being detected are the cathinones, and some of the novel stimulants there as well. Of the novel stimulants, it's a bit of a shopping list of cathinones that are being detected, mostly in MDMA. And also novel amphetamine there, 4-FA. Novel psychedelics. So psychedelics, there's with growing kind of acceptance of psychedelic medications in kind of clinical practice and in clinical research. We might be seeing more psychedelics, 2CB and 3CP, or certainly the subjects of drug alerts this year. And there's also a risk, there's an interesting conflation of 2CB, a novel psychedelic, with 2C or pink cocaine, which is a different type of drug, and people have been confusing those and getting very divergent experiences from what they've been expecting. The novel benzodiazepines are still producing drug alerts. So this year we've had bromazolam and bromonordiazepam detected, sometimes in other street Xanax or alprazolam. And then it hasn't, until yesterday, this hadn't been the subject of any drug alerts in Australia for the past year. But because ketamine use is increasing, so the last National Drug Household Survey had last 12 months use of ketamine being 300,000 people, which compared to MDMA of 400,000 people, it's kind of up there now with MDMA as a drug use of choice. And what have emerged are some analogues to it, which act a bit differently. They act longer in some cases, and also tyletamine, which is a veterinary medication, has been detected in some of the ketamines. This is from the Rabbit Eat Lettuce festival this year. This is the drug checking results there, and they detected all of those drugs in what was purported to be ketamine. In CanTest, there were some drug alerts in 2023 related to ketamine analogues. The first annual CanTest evaluation showed 57% having ketamine. In more recent drug checking, so Checkpoint in Queensland came online this year, they're finding a lower proportion not containing ketamine, but still up there. And then yesterday, Checkpoint put out a drug detection of Canket, which is the easiest of the three names to say, detection of that in methamphetamine. What we're working on now, Jack Freestone has joined the team, is working on another way of trying to get information around what drugs are being used to decision makers who can then triangulate that with other information around what harms might be experienced and what the actions that might be appropriate to do it. What I've got on the screen here is the Scottish anecdotal reporting system, where they actually collate anecdotal reports from across the Scottish health districts and actually put them online for people to see, as well as feeding them to the health districts that they've kind of emerged from. So we've started work on producing something similar to that in Australia. So that's my overview. I would really like to thank AVIL for their partnership on the PRN project and for the chairing of the PRN advisory group. The agencies that are involved in the Prompt Response Network really show up and bring their energy to the project of preventing drug harms. So I want to thank them for that. At our national meetings, Drug Trends, the Edna Project, and AVIL all provide national updates, and that's really greatly appreciated. I'd like to thank the members of the team at NCRED who work very hard on the Prompt Response Network. So that's Ed Broadbent, the project manager, Harriet, our research assistant, and Jack Freestone, who's our new research fellow. If you are interested in finding out more about emerging drugs of concern, the NCRED Symposium is the 22nd of November, back in Sydney again. We've got some speakers from the UK, and we've also got Cameron Truman and Lucy Stiles from High Alert in New Zealand, which has a very well-organised drug alert surveillance and risk communication system. And I've just popped that up there as well. The know.org.au that I referred to during the presentation as a resource for people who want to stay up to date with drug alerts. All right. Thank you very much.
Thank you, Brendan. I just remind people, if you want to post any questions, there's the QR code again. We will be holding over the question and answer session to the end of this session, and it's shrunk to only 10 minutes, so get your questions in and we'll do our best to answer them. But before we get to that session, I'm really pleased to introduce Rachel Sutherland as our next speaker. Dr. Sutherland, you may have heard her on the national radio this morning on the news. We're reporting on some recent results from the illicit and the ecstasy and related drug reporting systems, for which she's the program lead, along with the acting lead of drug trends for NDARC. She also currently holds an investigator fellowship, which most people in this room would know is very prestigious and only given to a select few. And her program of research is focused on monitoring systems for detecting trends in illicit drug use, including new psychoactive substances, and developing and evaluating novel responses to emerging drugs of concern. So you see a little theme here of this session. Thank you, Rachel. Over to you.
Thank you very much. So before I begin, I would just like to acknowledge the traditional custodians of the land on which we meet today, and would also like to acknowledge that I'm going to be talking about a national program of work that involves many different people and organisations and stakeholders, so a big thank you to everyone involved. And of course, would like to acknowledge our funders from the Australian Government Department of Health and Aged Care, who have been supporting this program of work for over 20 years. So for those of you who may not be familiar with drug trends, this is a national program of work which, as I said, has been running for over 20 years, and its overall purpose is to monitor trends in drug use, illicit drug use, markets and behaviours. And we do this through a number of different ways. So we analyse existing administrative data, so we produce an annual report on drug-induced deaths, and we also produce a report on drug-related hospitalisations. And then we also monitor online marketplaces, so in particular crypto markets and surface web marketplaces, to see what drugs might be being sold online. And then the third component involves going out and doing annual surveys with people who regularly use drugs. And that's mostly what I'm going to be talking about today. And so these surveys, we do them with two distinct groups. So we conduct surveys with people who inject drugs, and then we conduct surveys with people who use ecstasy and other stimulants. And important to note, these are not representative samples, but rather they're sentinel samples, which, as I said, are designed to detect emerging trends in drug use. So in the limited time I have, I am mostly going to be focusing on stimulants, opioids, and a couple of other drugs. But one of the notable findings for us this year was that we can continue to see significant changes in the perceived availability of MDMA. So we asked about 4 different types of MDMA, so pills, caps, powder, and crystal. And across all 4 forms of those, we had more people reporting that these substances were easy or very easy to obtain. And really this represents the continued recovery of the ecstasy market. So we saw some disruptions to the MDMA market back in 2022 due to COVID-19, and we've since seen that kind of market recover. When we look at broader kind of consumption trends of MDMA, so this is wastewater data, we can see that it has gradually been declining over time. So since about 2019, we've seen declines in the use of MDMA. It has been thought that this is possibly due to manufacturers in Europe who were producing MDMA have switched now to producing methamphetamine. That has stabilised somewhat in more recent years, but generally an overall reduction in MDMA consumption. What probably receives a little bit less attention is pharmaceutical stimulants. So we asked about the use of a range of non-prescribed pharmaceutical stimulants, and over time we have seen an increase in the percentage of our sample report using these drugs in a non-prescribed context. And the National Drug Strategy Household Survey, which is a general population survey of Australians aged 14 years and older, also kind of asks about these drugs for the first time in their 2022-2023 survey. and they found that about 2.1% reported that they'd used these drugs for non-medical purposes in the past year, and that's very similar to what we see for ecstasy as well. And we've also seen an increase in poisonings related to these substances. So these were from the Poisons Information Centre. This could potentially be due to increases in the prescribing of these drugs, but important to note that there are kind of increasing harms from these substances as well. Very briefly, the main points to note here is that cocaine and methamphetamine use and markets remain stable. So cocaine use among our sample of people who use ecstasy and other stimulants has been increasing over time, but has stabilised in more recent years, and markets remain mostly stable. So most people have no trouble accessing these substances, and typically pay about $350 for a gram. And this is fairly consistent with global market trends as well. So the United Nations Office on Drugs and Crime has been reporting for a number of years a prolonged surge in cocaine supply and demand. We also see similar trends in other data sources. So if you look at wastewater data, we can see that it does fluctuate over time, but it's overall relatively stable. And among the National Drug Strategy Household Survey, lifetime use continues to increase. But we have seen that past year use has kind of stabilised more recently. Similarly, with methamphetamine, use and markets are largely stable. So this is among our sample of people who inject drugs, and most people continue to report the use of crystal methamphetamine, and again, availability and price are stable. And again, this is consistent with what we see in the global markets. So the UNODC continues to report that methamphetamine markets continue to expand into East and Southeast Asia. And similarly, when we look at other data sources, so wastewater, very stable, and low among the general population. So as some of you may know, back in 2022, the Taliban banned opium production and cultivation in Afghanistan, and immediately afterwards we saw a 95% reduction in the production of opium in Afghanistan. So there was a lot of questions about what impact this was going to be having on heroin or opioid markets. We did see that production increased in other countries, and in particular, Myanmar overtook Afghanistan as the world's top opium producer, but it wasn't clear if that was going to kind of be enough to offset the disruptions that we were seeing to Afghanistan. And essentially what we found when we looked at our data is that heroin use and markets have remained largely stable. So at the moment, there is no real evidence of a disruption to these markets. So the majority of our participants continue to report using these substances, and as I said, no changes to price, perceived purity or perceived availability. What is important to note in relation to opioid harms is that when we look at drug-induced deaths or overdose deaths, opioids continue to be the main drug involved in drug-induced deaths, but we are seeing a bit of a different profile in terms of what types of opioids are involved. So if we look at this purple line, so that's the semi-natural and semi-synthetic opioids, so that includes your morphine, oxycodone, codeine. We have seen those kind of declining over time. And conversely, so that orangey yellow line represents heroin. And so we have been seeing an increase in opioid overdose deaths that involve heroin. There was a reduction in 2021, which we think was largely due to COVID, but this has jumped back up again in the most recent year of data collection. And these are preliminary estimates, so the coronial cases do take a while to close, so we expect that this number will only increase. So this kind of increase in heroin-related mortality is certainly something to be aware of and that we're keeping an eye on. Both Shane and Brendan have already spoken about the synthetic opioids, so I won't talk too much about this, but just to note that when we look at the new psychoactive substances on the market, a growing percentage are synthetic opioids. And the main point that I want to make here is that, we have been seeing some public health alerts from people consuming cocaine, what they think is cocaine and methamphetamine or ketamine, and then overdosing on opioids. And so for the past few years, we have been asking our participants, our EDRS participants, so our sample of people who use ecstasy and other stimulants, whether they've heard of naloxone and whether they're accessing this medicine. And good news that the majority of those sample has heard of naloxone, but very few people are accessing these substances. And so I think there's certainly an opportunity to be increasing awareness and uptake of naloxone among people who are not intentionally using opioids, but who may be unintentionally exposed to these substances. In terms of ketamine, so we have been seeing some reports of an expansion of the illicit ketamine market. So again, the United Nations on Office on Drugs and Crime released a report a couple of years ago on this topic, and it continues to be a key message in their World Drug Reports. And we've also seen an increase in ketamine imports into Australia, as reported by the AFP. And we also see increases in ketamine use among our samples. So ketamine use has increased fivefold over a 10-year period, although again, we have seen that's kind of stabilised in more recent years. And as Brendan mentioned, we are also seeing increased ketamine use among the general population. So lifetime use and both past year use have increased, and we're also seeing fairly increases in the wastewater sample as well. So I should have mentioned that with the wastewater data, the white bars are capital city samples and the grey bars are the regional areas. And just to finish up to talk about e-cigarettes, so as we know, back in 2021, legislation was introduced which meant that you had to require a prescription to obtain these substances. And then earlier this year, the importation of disposable vapes was banned. As we can see, this doesn't appear to have had much of an impact on use among our samples. What is interesting to note, though, is that we are seeing more people reporting difficulty accessing e-cigarettes or vapes. So about 20% reported that they had trouble accessing e-cigarettes, and this was largely due to the fact that where they were usually obtaining them were no longer stocking them, but also, interestingly, a lot of people were reporting that the price of these had increased and it was just too expensive for them to continue to buy them. There's also been further changes to vaping in Australia as of the 1st of July this year, which you may be aware of. They are now need to be legally sold through a pharmacy. You do still need a prescription to obtain them, but as of the 1st of October, I believe it is, they will be available over the counter. And there will be there has been further restrictions on disposable vapes, as well as restrictions on the advertising of these substances. In response to that, there has been reports of an increase in nicotine pouches, so importation of nicotine pouches, and concerns about these substances being marketed to young people in much the same way that e-cigarettes have been previously. So for those of you who may not know what nicotine pouches are, they're kind of like little tea bags almost that have nicotine in them, and then you pop them under your gum. So they're typically much more discreet than a vaping product. They come in a lot of different flavours. And we were able to sneak in a question about the use of nicotine pouches among our sample in our survey. And we do find that about 1 in 5 of our EDRS sample reported using these nicotine pouches. So I think this is definitely an area that we need to continue to watch. And then just to finish up, I want to go back and talk about drug monitoring systems more broadly. So in Australia, we have really fantastic drug monitoring systems, but I think there is a bit of a missing piece. So there's essentially should be 3 pillars of a drug monitoring system. The first pillar is around routine monitoring. So this tells us what has happened, and it's generally quite robust data, but it's quite reactive. And this is where some of our mortality or hospitalisation data might fit in, so the data's quite lagged. The second pillar is around signal detection, so that tells us what is happening. So this might be a bit more speculative, but that can include things like the prompt response network, the drug alerts, and the toxicological data that EDNA produces. But then the third pillar, which we are missing currently in Australia, is around foresight or horizon scanning. And this is around what might happen and what can we do to prepare for this. And obviously the first two pillars are very much dependent will feed into the foresight or horizon scanning pillar, but the foresight or horizon scanning is very much an independent pillar that we should be looking at more in Australia. And I think the concern around nitazines really highlights the importance of this. Just to flag that our annual reports are now available on our website, so if you're interested in finding out more about those, please head along to our website and check those out. We've also got a bunch of really great poster presentations, which you may have already seen, one of which is on the availability of nitazines on crypto markets, but also looking at GHB-related harms and use, as well as a range of other topics. And if you have any further questions, do feel free to get in contact with us.
Thank you, Rachel. We do have question time. I've been told we've got until 12:43 to finish the question time, but I'm aware that people are probably keen to get out and have some lunch. So I'm going to keep things moving. I'm actually going to ask Shane and Brendan to join Rachel and myself here on the stage. And I think Brendan and Connor are in. No, Brendan's going to give the microphone to Connor. Amir's going to bring the microphone around to anyone that wants to ask questions, so just put your hand up and Amir will be there with you. And we do also have some questions here on the iPad from the Slido. And I'll take the first question. It's pretty much for all of you, but let's start with Shane on this. And the question is, how do we respond to stimulant overdoses? What harm reduction strategies can we follow and educate community to reduce the poisonings and deaths related to stimulant use?
I mean, it's a trickier issue than it is with the opioids because we have naloxone. I think one of the things I would educate people that the risk, the cardiovascular risk is real. And I think, for instance, I think if someone is using regularly stimulant drugs and they're under the care of a GP or in a treatment setting like Nadine's unit, regular monitoring of cardiovascular functioning I think is crucial. The answers aren't as obvious. There's no one drug we can do that can intervene to stop it. But I do think it's important to people to be aware of the nature of risk. People can't change their behaviour. And the second thing I think is related to that is people recognising the signs of a stimulant overdose. People know very much what a sign of an opioid overdose is, but a stimulant overdose, a number of the deaths I saw where people put people in the shower to cool them down, and they're not cooling down. They've got a temperature of 41 degrees. Putting people in showers it's been a very popular intervention, but it's a terrible intervention because all you've got is wet people who have overdosed. So I think recognising in a situation like that, no, you need an ambulance. So I think people around recognising this is serious. You need an ambulance. Full stop. Sorry, I can't offer anything more, obviously, but it's a tricky problem.
Thank you. Thanks for taking a stab at that because it is tricky. I'll take the next question. I think this is for you, Brendan. What key lessons do you believe the Australian environment can learn from international ones regarding emerging drugs? And your answer in 1 minute, please.
I don't need a minute. I can say, come to the Symposium, listen to New Zealand's talk. They have a very fluent system. They have had drug checking a very long time. So a lot of the technologies that we're incorporating in Australia, they don't need because they get very good reports. They have very good cooperations between their sectors. So I always point to New Zealand as a really good example. And then, some of the work that's happening in Europe about just the amount of toxicology testing that's available. The anecdotal reporting system will be really interesting, but toxicology is what you need to actually confirm what's happening in the community.
Thank you. I'm going to take another question for you, Rachel, from Michelle. Question 2. Do you see a problem with lack of regulation around veterinary medications? Because I think you mentioned some of the ketamine and things sold as ketamine were actually veterinary medications.
That's a great question. A little bit difficult for me to answer. What I would note is, so in that UNODC report that I mentioned a while ago, they noted that back in the 2000s, a lot of the illicit ketamine seemed to be from diverted legitimate channels. So, but more recently, so in 2015, I think the government of China reported that there was an increase in clandestine laboratories who were kind of synthesising and producing ketamine. So, and that's kind of what was driving this expansion of the illicit drug market. So given that there has been that kind of expansion of clandestine laboratories, I'm not sure that regulating kind of vet practices would achieve too much. Yeah.
Great. All right, thank you. And another tricky one that I'm going to give to you, Shane, just because of your breadth and depth of experience, and this is a tricky one. How do we get police and legal systems on board with harm minimisation, including overcoming resistance to naloxone?
Back in the 90s, back when I was a lad, we actually worked with South Australian Drug Services, Ambulance and Police had an event like this, and you can change things. For example, in that particular case, Ambulance and Police were all going through the same thing, same call-out, so the police and the ambulance both turned up to an overdose. Behaviour was changed then such that police only came if there was a death or threat. So I think, I think things have changed over my lifetime for the better. But I think involving people and getting the key sectors talking to each other, you can actually make progress.
Mm-hmm. Great. And I think we are seeing progress because in Western Australia and Queensland, police are carrying naloxone, and we hope to see that in other states and jurisdictions too. So yeah, you're right. Brendan, I've got another one for you. Again, a tricky one. Again, you're limited to 1 minute. How can we get drug and alcohol working with mental health?
New psychoactive substances for everyone. I refer you to Shane's answer, probably getting people in the same room to talk to each other about what the shared concerns are, and that our solutions are most likely better off together rather than working in silos.
Thank you. And one for you, Rachel, specifically directed at you. What could foresight research look like? Are there any good examples?
So it is currently being done in the European Union, and it was mandated by government. Michaela has actually done a lot of work on this, so she's probably better equipped to answer this than me. But essentially what they do in Europe, my understanding, is that they will do things like stakeholder interviews to determine, topics of interest. They will do some environmental scanning, not just within the drug and alcohol sector, but also kind of looking at megatrends. So that can include things like climate change, technological advances. It's much broader than just, the drug and alcohol field. And then they will produce, out of those kind of different threats or kind of concerns that they may have identified, they'll pick 3 that are kind of the most, that might be most likely to eventuate, and then they develop some kind of plans around those. And, in a lot of cases, they might not need them because it is largely speculative, but it is very much around making sure that we have the systems in place so that if things like nitazines do take off, that we're equipped to be able to respond appropriately and quickly.
Thank you. That's very comprehensive. Thank you. there's a couple more questions here on the Slido process, but are there any questions that people actually want to ask themselves using the microphone in the old-fashioned way? Because we are down to the last 2 minutes. I'll take a question from the audience that doesn't want to type. Otherwise, we'll move to just one last question here that I've got here, and I'm not sure who wants to take this, but maybe. Oh, sorry, there is one. Where? Oh, great. Oh, thank you. Sorry, Amir's just coming with the microphone because I think we might have people online. Just hold on to just speaking to the microphone. Thank you.
Thank you very much.
Thank you.
Okay, speaking of silos, are there any mental health representatives in the room today or organisations? Could you please put up your hand if you belong to a mental health organisation, peak body or other, and you're in the room today?
We welcome you.
One. Thank you.
So we've got a handful, hey? Yeah, thank you for that question. There's clearly some more work for us to do there in terms of bridging collaborations. All right, one final question in the last 1 minute, and this might perhaps be for you, Rachel. Does the increase in ketamine use have any correlation to its use in the treatment for chronic pain, and how do you see the increase in recreational use impact clinical care? I can take the second part. We don't, but the first part, off you go.
Yeah, I mean, it's difficult to say. I mean, we can, as we saw from our data, it has been increasing for a number of years. And I think part of that is, as I said, due to the expansion of the illicit market, whether it's been driven by, its use in clinical care, probably a little bit difficult for us to say.
But would you say most of the market comes from illicit rather than diverted from human clinical care? Yeah, I think the relationship is quite slight. Yeah, good. Thank you. We're down to the last 18 seconds. Thank you very much for bearing with us. Enjoy your lunch, and we'll see this afternoon. We're going to the breakout sessions, so we'll see you in the breakout sessions. Thank you very much for being with us this morning.